Welcome, friends, to the Healing Cancer Journey podcast, where we explore questions about the role of psychedelic medicines in our cancer journeys. I'm your host and fellow explorer, Dan Callahan. Why does modern cancer care excel at shrinking tumors, but struggle to address fear, isolation, and existential distress that defines so much of the cancer experience? In today's podcast, we're speaking with Dr. Manish Agrawal. Manish is the founder and CEO of Sunstone Therapies, called the world's most active psychedelic research site. Before building Sunstone, Manish spent nearly 2 decades as a practicing oncologist. Manish holds an MD from the University of Alabama, a master's in philosophy from Georgetown, a master's in clinical research from Duke, and he completed fellowships at the National Institute of Health in both oncology and bioethics. Needless to say, Manish is uniquely qualified to share an informed perspective on psychedelic medicines and cancer care. In this episode, Manish and I talk about how modern oncology is really incredible at extending how long we live, impacting quantity of life, but that our system often struggles to address quality of life, the existential distress, the fear, the isolation that so many of us face in our cancer journeys. Manish and I discover why psychedelics create something he's never seen in his years of practicing medicine. Profound shifts in perspective within days rather than months or years. And we dig into the open questions that still remain about dosing, about which patients benefit from which medicines, and about how to provide safe access as these treatments move towards FDA approval. Throughout our conversation, Manish emphasizes both hope and humility. Even after overseeing several hundred psychedelic therapy sessions, Manish says he knows less now than when he started. But his curiosity, that willingness to ask questions rather than claim expertise, is exactly what the cancer community needs as we navigate this emerging field. During the conversation, I was really struck by how effectively Manish navigates between both the science and the humanity of psychedelic medicines and cancer care. We have a very in-depth conversation about clinical research, but more importantly, Manish talks about love and meaning and even God. And as a cancer patient, it's so refreshing to hear an oncologist be equally comfortable in the worlds of science and humanity. Of course, this podcast is brought to you by Healing Cancer Journeys. We're a nonprofit providing education and community for people exploring psychedelic medicines in their cancer journeys. You can find us online at www.healingcancerjourneys.org or follow us on Instagram, TikTok, YouTube, and Substack, where our handle is Healing Cancer Journeys. And as a reminder, today's podcast is for educational and documentary purposes only. It is not intended as medical or legal advice. Thanks for listening, and I hope you enjoyed today's episode with Dr. Manish Agrawal. Manish Agrawal, welcome to the podcast.
Thanks. Appreciate it, Dan.
So, Manish, we're going to be talking primarily about medical topics, cancer and psychedelics. I want to start outside of the medical realm. You have a master's in philosophy, which you completed during your medical residency, but would love to understand a little bit about what you took away from your studies in philosophy and how those studies shaped your approach to cancer care.
Diving right in.
Easy question out of the gate. The big philosophical questions.
It is big philosophical questions. My interest in philosophy has been for as long as I can remember. Just sort of big questions around, since we're diving right in around, like, why are we here? What's meaning about? What makes sense? What does it mean to be human? I don't even know if I could articulate all those things exactly, but I was always asking those sort of questions as long as I can remember. Philosophy seemed to be a discipline that maybe addresses, or at least talks about those. And so, I want to study philosophy in college. Being an Indian immigrant, that's usually not the most popular major.
What did your dad have to say about that?
He said, I didn't come to this country for you to be a philosopher. So you're either a doctor.
You became a doctor, so you made Dad happy.
Engineer, doctor, or a lawyer. Those were the acceptable professions. So I actually went into engineering. And found that to be really interesting. And actually I use that because it helped me problem solve and be analytical. But I realized I wanted to do something that was more uh, directly involving people. And so I thought I was going to do biomedical engineering, ended up going into medicine in medical school. And then surprisingly, in medical school, I really liked talking to patients and like being a doctor. And I was like, well, maybe I don't want to do biomedical. And, uh, and at the time, there was only one program in the country that allowed you to do a master's in philosophy and do an internal medicine residency, and that was at Georgetown. So this guy, John Eisenberg, who's passed away now from a GBM, a brilliant guy from Penn, started that program because he saw like the need for physicians and humanities to cross. And so it was a great program, and I ended up studying philosophy, which was like worked out even better because I think it's better to study it later in life than as an undergrad. And it really probably changed my thinking about a lot of things in medicine. Um, and it's the way I really like, in that I'd be in medicine, but then I would take a semester off and take philosophy classes and think about what I was doing and then go back into it. So like a couple of books that affected me a lot. One was by Eric Cassell. It's called The Nature of Suffering. He really stepped back and talked about what the patient experience was and how a patient isn't just their disease or their label or their blood pressure, and it's this human story, and sort of a dense book. But then I could go to the ward and then see like how we said, you know, the guy in 6400 with hypertension rather than the person and why he was there. Another book that affected me a lot at that time was Paul Starr's book, Social Transformation of Medicine. And they really talked about how doctors were the same as sort of shamans. You know, shamans were like leeching people with blood and doing different things, and then doctors were doing their thing. But all of a sudden, came and doctors got legitimacy. They were able to cure people. Then the boards came and became this profession, and the AMA and the politicalization of it, insurance companies, so it sort of separated out widely, and how this political, social, economic machine that became modern medicine and why, and how it diverted from that. So it really helped me reflect on what it is that we're doing, what the task of medicine is ultimately, you know, at its roots, while practicing it in the modern era. And so, and so it affected me tremendously within medicine. And then the field that I really liked, so you're gonna learn to ask me less questions because I go on and on here, is is epistemology, which is really about how do we know what we know, and it's about the big things, about how we know anything. But then it really applies to medicine, and like made me start thinking about like what counts as medical knowledge, you know. And so I took a great class called Feminist Bioethics, and you know, the woman that taught me was brilliant. It was like, so men have typical chest pain, but women have atypical, or you have a normal kidney function, but you correct it for a black person. So how do we collect who's normal and why do we correct it for certain people? And so starting to see how medicine itself is interpreted within who's, you know, telling the story. And so that all those things really affected my thinking, and you know, I've carried with it the whole time.
And it sounds like, one, it led you to ask these big questions about why, which become really important in medicine, so that we're not just blindly accepted what came before us, but really challenging why we're doing what we're doing. And it also sounds like it gave you a human lens on the medical experience, which I think you're right. Sometimes that medical experience, patients are flattened into a medical chart or a case, and it sounds like you've carried that into your career. And of course, your career, you completed your residency at Georgetown. You did some work at Duke and at National Institutes of Health. And then you were a practicing oncologist at Maryland Oncology Hematology for almost 2 decades. Tell us a little bit about that experience as an oncologist and some of the gaps or challenges that you saw in cancer care.
It was a really meaningful time. After my finished my residency, my fellowship at the NIH, I stayed on faculty there and did research. What I learned during that time was how much I really enjoyed patient care. I just published this paper in JAMA and had another paper at JCO, and then I told people I was leaving to go into practice. My mentor was shocked. He was like, "You've got publications, you could be chairman." And I was like, what gets me excited is really talking to people. And this other stuff isn't that exciting for me. And that's ultimately why I went into oncology and in private practice. And that was very fulfilling because I had such deep, meaningful conversations with patients about things that mattered. And, um, when you have cancer, everything sort of strips away. You talk about, like, why am I here? What matters to me? What relationships are there? And to be able to be with people in that moment was very powerful and fulfilling and tiring, and it helped me grow in many ways, just as to be in that experience with people.
And you talked about suffering earlier, and sometimes those moments of suffering can also be the most meaningful moments of our lives. And for you to be able to be with patients in those challenging situations, I imagine was also meaningful and fulfilling for you. And yet you left clinical practice. You decided to stop being an oncologist. And tell us a little bit about why, or some of the challenges or frustrations that you faced.
Yeah, I think so. I enjoyed my time there, but over time, what became clear is we weren't really trained how to talk about the things that were the most relevant in the room. When you have cancer and you walk in the room, yeah, you want to talk about what treatment you might get, what are the side effects, what's the prognosis, but the other things that come up are like, why did this happen to me? What am I going to do with my family? What's the meaning of life? I don't want to die. And believe it or not, in training, nobody really talks about that. And, the big cancer meetings, there's not a lot of posters and presentations on that. It's a lot about how well the drugs work. And yet, this is probably the most important question on people's lives. So that's one element that became clear. And then over time, what I saw was that even though I was able to take care of people and help give good cancer treatment and shrink the tumor people lived, the suffering was caused by these other things and didn't have very good tools to deal with that. Didn't have training, but even when with the training and as I developed good skills around that, um, I don't think that there were adequate tools. And so I would give people bad news or talk to them, but then they sort of are left on their own, and we hadn't really developed a lot. And so that caused, some burnout and actually depression for me, just my own suffering to see that. And so I think seeing those two things together, and then at the same time, I'd never heard of psychedelics, honestly, until a few years ago. And so, but what impressed me when I first started reading about psychedelics was that they talked about the thing and named the thing that was the most common, what we saw every day in oncology, but that we never talked about, like existential distress and suffering and anguish from having cancer. And not only did they talk about it, they said that it actually is something that might do something about it. So that really got my ears up. And um, so that sort of led me to investigate it more. And then when I learned that this might be real, even though I'm skeptical, I said, we gotta try it.
Yeah, that existential distress. I'll tell you a story. I asked that same why question of my oncologist. Why did this happen to me? Did I do something wrong? Was there some sin or karmic event that I was guilty of? And I still remember his response. He's, I don't know. Like, we just don't know. There might be genetic factors. There might be some experience or exposure environmentally in my history. But the reality is you don't know. And to both suffer and not know why you're suffering, that just amplifies the suffering. And that is absurdity. And that question of why am I suffering and being able to make meaning from suffering is just so powerful. And you talked about beginning to kind of discover psychedelics yourself. Tell us a little bit about that discovery. What was your entry points into psychedelics? How did you bridge that world from oncology into psychedelics?
Yeah, so it was right around that time when I was um, thinking about these things and finding my own. I just wasn't finding it fulfilling anymore to be an oncologist because I'd gotten really good in terms of the technical aspects and what drugs to use and even the conversations, but I felt like I wasn't able to really move the ball on that. And um, that's when I'd gotten introduced to like the topic of psychedelics, and somebody sent me a paper, and then just down the street uh, was Roland Griffiths, who's passed away now. Um, so I called him up and said, I want to talk to you about this. And so I went and visited him and Mary Casamano, neither who's at Hopkins anymore. Um, they said, yeah, we see these really powerful stories. And in talking to them, it became apparent that there's something really powerful here. And then when I started reading, I said, wow, there's a lot of history and literature. And so at that time, I also ended up signing up for a course in something called the California Institute of Integral Studies. And it was the only sort of course that was available at the time. It was a year long that taught you about psychedelics and psychedelic research. And so I did that, and at the same time wrote a study that we conducted using psilocybin for cancer patients. And so this is where everything sort of started coming together. Um, Engineering and then medicine and philosophy and oncology, like where does it all fit in, and research? Why did I do all these haphazard things? You know, Getting to use my research skills to ask about basic philosophical questions with cancer patients as an oncologist sort of all made sense.
Of course, Roland Griffiths has his own journey with cancer, and I'm curious if his cancer journey ever came up in those conversations about psychedelics in your time with him.
Yeah, so when I met him at the time, he didn't have cancer or anything like that, and then ironically, he did develop cancer, and then we used to talk about it all the time. In fact, I did an interview with he and his wife to talk about his cancer journey and how it affected them, and it's on our website. And it's one of the most meaningful conversations I've had. And just, it was this conversation of I'm an oncologist and he's a cancer patient. I'm a psychedelic researcher. He's a psychedelic researcher, and we're talking about all these sort of big topics. It was a really fun conversation. And it affected him tremendously, and he would be okay with me telling you, like, it's one thing I tell people, like, until you have cancer, it's just all theory. So even though he studied psychedelics, studied meditation, worked with cancer patients, until he had cancer, it didn't become real, and it changed him. And that's what we talk a lot about. And so, I have a lot of respect for cancer patients because until you walk through it, it's all just theory.
Yeah, yeah. There is tremendous wisdom in that experience, that lived experience of having gone through the cancer journey. Um, I completely agree that it's one thing to have the theoretical knowledge, and it's a whole other thing to have the practical application in his cancer journey. And so you started Sunstone in 2020, I believe. And tell us a little bit about what Sunstone is and kind of how it became an outgrowth of some of those previous experiences as an oncologist and your conversations with Roland Griffiths and others.
Yeah, so the first study we launched was using psilocybin in a group setting. It was the first study done with a group. And then I was still practicing as an oncologist and did the study as a principal investigator.
Interesting.
And about, I'd say 3 or 4 cohorts in, which is about 16 patients or so, you know, I was actually just blown away. I was somewhat skeptical, even though the literature was there, people talked about it. I didn't really think it worked that well. But what I saw was that in a very short period of time, like within 3 or 4 days, people were really different. And I had never seen anything in medicine that was so powerful so quickly. And I also saw that this is really complex care. And these are very powerful drugs, very powerful medicines that we just have no idea how to use. There's a lot of hype around them, and to really understand how to use them is an endeavor to itself. And so, there came this existential moment for myself: is am I going to practice for another 15 years and do what I'm doing, or am I going to like quit my secure job and go into this unknown field um, to do this? And I realized if I didn't do this, I'd always regret it. And so Kim Roddy, who's my co-founder, she ran the cancer center, and we talked about it, and she's so let's do this. And so that's sort of what started. Is like I knew this was real. I knew it was a very powerful medicine. I didn't know how it fit in, but I wanted to study it further and to figure out how to make it safe and accessible. So Sunstone Therapies was founded with that mission of, not about drug development and working on the drug particularly, but how do you actually take care of patients in the real world using these medications that are coming? Who is it safe for? What's the best setting? How do you prepare people for it? All the different aspects. It's like a new specialty that was being born, that is being born, and how do you bring that into being?
Yeah, and patients were at the heart of that. That to your earlier point, it wasn't about psychedelics necessarily. It was about patients. It was about safety. It was about access, and it was having the patients in the center of that lens. You talked earlier about having some initial skepticism, and would love to hear a little bit about the roots of that skepticism.
Um, just skepticism in that, people always talk about how well things work, and um, most things in life usually disappoint, right? They never quite match up to the hype.
Yeah.
Um, and so, especially in medicine, like this promising drug, and it moves the ball a little bit, but doesn't sort of change things. And so I think that was that real skepticism. And then there really isn't anything in medicine like this. It's like most things affect objective measurable things like blood pressure or tumor size, but this affected something, the way people feel, the way they looked at the world, and there's just no example for it. And so until you sort of see it, it just doesn't make sense. And so I could see somebody who was really stuck in fear and distress, and then they would have this 8-hour experience with a lot of support. And I'm not saying it's magic, but they would come out, and it's like they were stuck in a ditch, but they were starting to move again. Now that things were fixed, but there was a real change in perspective, and there's not an equivalent for that in medicine. I mean, I think some people might have it like during birth or near-death experiences. It can be very powerful, and people get to that edge, and then somehow that experience changes it. But that's sort of a rare, unplanned event. I've never seen it in medicine where you actually plan on someone having a powerful experience.
And I think that skepticism mirrors where we are as a society. That skepticism is healthy. It's part of what keeps us safe, and you're kind of seeing eyes opening. And you talked about after about the third or fourth cohort seeing something, and I'm curious to know, was there an aha moment? Was it the sum of those 15 or 16 patients? When did the proverbial light bulb go off?
It was really the patients, the participants on the study. I mean, it was the words they used, so I can say there was healing and there's overcoming of fear, but the way they would describe their stories and the words they used, what was transformative for me. It was like they were coming in for help, and then after they were done, the stuff they would say, the therapist and everybody else taking care of them was help. It was like the roles were reversed. We were helping them, and they were helping. It changed the way they were helping us, because just the wisdom they had was sort of mind-boggling. So that was the aha moment. Was like, wow, where did they come up with this stuff? And the insights were really powerful. Like, I could see a person and say, oh, maybe they should think about this or work on this, and they might agree on that. But then the experience they had would take them in a different direction, and no amount of like human intelligence, left brain thinking could concoct that experience um, with all of my brain power. It was like their own psyche took them to places that was helpful for them. And that was really, and then the way they articulated it was in their words that was the most powerful thing. I still find the most powerful description of psychedelic experiences is from the people that have gone through it and when they describe it.
Yeah, yeah. And it's interesting just the power of storytelling to take those psychedelic experiences, which can be really hard to wrap language around sometimes, and to take that difficult to describe experience and to have a story against it is really, really interesting. And that's transformative, not just for the patient, but it sounds like it was transformative for you as a clinician to kind of move from being skeptical into perhaps where you are today.
Yeah, I mean, I think it's, if you go back to sort of the epistemological roots in philosophy, I mean, what we don't always realize, it took me a long time, we sort of have a default materialistic worldview in medicine and in science and in the world. And so, like, when you go to the doctor, you never think about talking about love or about death or God or these esoteric concepts that don't necessarily have material, you can't measure those things. And yet, those are probably the things that give you meaning and carry you through everyday life. But they're sort of outside of the context of the medical practice and what you might talk to your doctor about. Yet those are the things that make you human. And these medicines bring those things to the forefront. And so, of course, we don't have a language for them because it's not been part of the recent history around this. And not around this, but around medicine. It's just not been part of our language. We aren't taught those things in medical school. And so I think that's some of the challenges these medicines are going to bring to the practice of medicine is we're going to have to start developing language for these things we excluded from our epistemic because we didn't think they counted that much. But now, because they're so prominent and so in the forefront, we're forced. How do we describe them? It's not going to be a CAT scan. It's not going to be an MRI. It's not going to be blood work. It's not going to be simplistic words. We're going to have to find, and philosophers and mystics and skeptics, they're the ones that wrote about these sort of things, but that wasn't never sort of the things that was in the field of medicine, but now it's having to be dealt with it because it's the experience of patients.
Yeah. How do you measure love? How do you measure meaning? And to listen to you talk, I always think about transformation as a result of a psychedelic journey at the individual level, but I'm also hearing your experiences as a clinician watching other people be transformed shapes how you think about your role, shapes how you think about medicine. And it's kind of an interesting paradigm in terms of psychedelics and how that might help the broader community think about the broader healthcare community think about their role in not just shrinking tumor size, but loving their patients and helping their patients find meaning. And that is potentially just so, so, so powerful. I want to talk a little bit about Sunstone. So Sunstone has been called the world's most active psychedelic therapy site. Was looking on your website, I counted 17 trials, either completed or ongoing, 5 of them specific to cancers, 5 different psychedelic compounds and their respective analogs, over 250 psychedelic sessions in the last 2 years or so. So just a wealth of science, and you're in a unique position of overseeing that science. And I'm sure it's hard to summarize, but if you were to kind of boil it down and simplify for the cancer community what the science is telling us about psychedelics, what's that take-home message?
Another easy question.
Good. I just want a bumper sticker. Just give us a bumper sticker, Manish.
Invited to be an expert on panels and stuff. And the more I've done this, and it's now like 400 treatments or so, and So I feel like sometimes I know less now than when I started, and so I'm the expert of nothing. I'll say that. But I think that the drugs, the medicines are catalysts, and the work is really done by the person. And so what you're looking for is not the drug, and people can get fixated on the drug. We just treated some people last week, and it was in a relational setting, and what the drug allowed was the love that was already between the people to really start moving again. And the love between them is what healed. It wasn't the drug, but the drug was a catalyst to get that going. And so that's sort of a subtle thing to hold, because it's easier to get enamored with the tool. And the tool is important. Like, you can't build it, you can't do it without it, but it isn't the thing. The thing is what's already a natural human capacity, which is to love and to feel. So those are the things that get activated.
And I wanted to talk a little bit about that. So you are doing a lot of group settings. So two trials specifically, or two studies specifically. One I think you were just referencing is the MDMA dyad study, so a patient and a loved one. You also talked earlier about psilocybin group therapy. Tell us a little bit about that group setting, and why that group setting is important, and perhaps maybe even a bit novel in research.
Yeah, it shouldn't be so novel, but I think it's very powerful. I've really been blown away by the power of group. And so, I think if I was going to summarize it, to have cancer is in many ways isolating, because until you have it, you don't really know what it's like. And then a lot of people that have it don't talk about it with others, because you end up taking care of the people. Because once you tell them you have cancer, they're like thinking about, what if I had cancer? So you end up helping them instead of it being about you. And so a lot of times cancer patients are carrying that alone. And the psychedelic experience can be quite powerful as well, in that it's, as you said, there's not always language for it. It's not your everyday experience. And so when people share these two powerful things together, the isolation of cancer and then the connection of this powerful journey, it bonds them in a way that very few things that I've seen happen. And and then having that community to be able to share that experience and their struggles is very powerful. That lasts far longer than the psychedelic experience. And so, like, when you ask, why did this happen to me? Or did I do something wrong? But then when you see others ask that question and they struggle with it, you're able to benefit yourself from seeing their struggle, and you can say, that is a nice young person. They didn't do anything to deserve that cancer. That's just absurd. And see how they beat themselves up for it. And so that's a very powerful experience. And I think that human connection, and that shared journey we've seen again and again, is probably what is ultimately healing and helpful. And I think the psychedelic just catalyzes and facilitates that connection.
And that's something that we think about a lot at Healing Cancer Journeys, is creating community, because that community is so important. And I think that you're right that cancer is just so lonely. It's lonely being by yourself in an infusion center, lonely being by yourself in a hospital room, and just being with other people who share those experiences, completely independent of a psychedelic journey, is powerful. And then when you layer in the psychedelic journey, where you are perhaps more open, and you are perhaps more available to those feelings like love and meaning, to be able to do that in community is just so powerful. So I'm just really excited to hear that you're exploring those compounds in group settings.
Yeah, and it's not just the feelings of love and meaning, it's also the feelings of grief and despair and loneliness and sadness. And, I think that's really the isolating part, because people feel sad or they feel despair, but they carry it alone and don't share it with others, which doubles the burden. And so to be able to do it with others that have the same doesn't make that go away, but it just is not isolating, which doesn't make it worse. And so I think that's really the powerful part of it, is those other things that people are carrying alone in isolation, they can share with others without having to burden or force it on others. I think is really powerful.
We've talked about psilocybin, we've talked about MDMA. When I looked on your website, your studying 5 different compounds in cancer. Specifically, it's predominantly psilocybin. I think you had 4 psilocybin trials, 1 MDMA trial. Would love to hear a little bit about why psilocybin, at least today, tends to be the predominant area of exploration in cancer.
Yeah, so we have one other study, a novel drug called RE104 that's used looking at adjustment disorder. And so, I think some of it's historical. It's been traditionally studied in cancer, but in our dyad study with cancer patients and family members, we found MDMA to be very powerful and to really help people with those experiences. There's not really been any study that I'm aware of that compared MDMA to psilocybin in anything. And so I think ultimately, as these drugs move further along, we'll be able to figure out which one is right for which person and in which setting, depending on what they're going through. Um, Traditionally, psilocybin is thought to be a deeper experience, perhaps more body, and uh, lead to quote a more mystical experience. But I think some of those are, a little bit true, but not sort of fact. And I've seen people with MDMA having really powerful experiences, and people with psilocybin not. And so I think it's much more nuanced than sort of the current portrayal of these medicines. We're just at the beginning of understanding these drugs.
Yeah, yeah. And kind of by exclusion, LSD, DMT are less studied, at least today, in cancer. Any particular exclusions, or why not LSD or DMT?
I mean, LSD, I think certainly could be. Again, it's just a resource issue, and so it's a longer acting drug, so it takes more resources. MDMA is 6 hours or so. Psilocybin is maybe 8, and then LSD is starting to get into 10 hours, and so it's just a lot longer session that can be hard on cancer patients, but I think it would work. And 5-MeO is a very intense treatment, and it's been used for depression, but I think all of those should be studied in cancer patients to see are they different or not. So, ideally, I would love to have a study where I'm using all of those different settings in different cancer patients and trying to understand which profile is better for which person. But it's a resource issue more than, I think, a priori we know why one is better than the other.
Okay, good. I put a pin in that question. It's something I want to come back to at the end of the conversation, just in terms of your hypotheses about all of those different compounds and different sets and settings for what types of patients. But let's put a pin in that. Um, you also mentioned earlier studying psychedelic medicines in adjustment disorder. It seems to me like some of the earlier research was done in major depressive disorder, and more recently we're moving into adjustment disorder, generalized anxiety disorder, which are kind of comparatively less severe than MDD. And I'm just curious, what is driving that trend? I think I'm kind of driving at, do people living with cancer need to have severe depression to benefit from psychedelic medicines?
Yes, I mean, that's not really a psychedelic question. This is more a drug development thing. So this
Hmm.
is all driven by labels for the FDA and insurance coverage. And so, in order to get a drug approved, it has to have a DSM diagnosis. And we could have a longer conversation on the DSM and what it is and its validity. And it's a bunch of little white guys talking about diseases that. And so, what's the validity around the DSM? And so, in truth, cancer patients or any person has a bunch of symptoms, and then we put them into these categories. But you can't go to the FDA. Existential distress is not a DSM diagnosis. Like, you understand what that is, you understand what it feels like, but it's not a DSM diagnosis. And so you have to have depression or generalized anxiety disorder or adjustment disorder. But most people walk in and clinicians would tell you this, most people have comorbidities or co-diagnoses. So you'll have some depression and you have some anxiety, and that's just how you feel. But then we have to sort of put you into this bucket. Um, and so I'm not, I think there's some validity. I don't think it's right for everyone. but as a person, you're not necessarily going to experience one thing. You're going to experience multiple symptoms, and they may fit into a classification or may not, but that's a limitation of the classification, not a limitation of your experience. And we're putting you into a classification in order to get a drug approved and to have insurance coverage, which are all important things, but they're not necessarily the experience that a person has. And then I think your question was, is it only for major depressive disorder? You know, having seen we've treated a lot of people with major depressive disorder, and that's a wide range of people, people with mild to severe treatment-resistant depression. Um, and I don't think that category is enough to capture who it's right for or not. This adjustment disorder study, where I mean, not to get into some of the details, but I helped sort of design it, and they had adjustment disorder, but they couldn't have people that were too depressed because they wouldn't have adjustment disorder. But if didn't have enough symptoms, maybe they wouldn't benefit, and so now they're allowing people with depression. I mean, it's complicated because it's not as easy as cancer, in that if you have a tumor, I can measure, is it 4 centimeters, is it 6 centimeters, is it shrink or not? When you have something how you feel, we don't have good ways to measure that, and we don't have good ways to measure it. I have to put it into these numbers that are somewhat not artificial, but not as objective as biological things like tumors. And so that's why you're seeing these limitations. And it's not psychiatry's fault in that they picked the hardest organ. The brain is the hardest organ to study. It's not like the heart or the liver or the kidney. And so that's just where the science is.
It's hard to measure. It is really hard to measure. It's hard to objectively measure an experience. You can't say an experience is 2 centimeters by 3 centimeters on an image. It's just much, much harder to experience. I think the point that you made about the gap between these DSM diagnoses and the actual patient experience is really, really, really important. I was trying to understand the incidence of major depressive disorder and general anxiety disorder and adjustment disorder in cancer, and the numbers are shockingly low. It was, a quarter have major depressive disorder, depending on the study, and 40 or so percent had any one of those mood disorders. And to think about someone being diagnosed with cancer and not experiencing at least some depression, not experiencing at least some impact, is shocking to me. And so the gap between the measured incidence of those disorders and the actual lived experience of cancer patients is just tremendous. And I hope that someday we can close that gap.
Yeah, I mean, I think it's around measurement. I mean, it's a complicated thing. It has to probably do with, I talk about the collusion of denial. And it's not that people get together and say, let's deny the symptoms that cancer patients have. You learn to wall off your feelings or those symptoms in order to get through the day, in order to show up, get your chemotherapy, go home, cook dinner, be with your family, and then go to your job. And so, in a way, you have to keep them at somewhat bay so you don't over-report those symptoms. And then the nurse or the doctor is like, how are you doing at 15 minutes? And so, did you have nausea? What's the tumor size? How are you feeling? Fine. And then you go to the next thing. And so all of a sudden this thing just gets a smaller role. And so if you actually created space and people sat down and got into their feelings, I think you'd find a lot more. And one of the things that really surprised me, and I was humbled by in treating cancer patients, is how some really protected their feelings of grief and sadness, and to be very careful and not, if they were protecting it, not to sort of go in and say, well, let's talk about it because I can see it, it's there, because they may not be ready to deal with it fully. And so there's some under-reporting or under-talked about because they literally don't have the space to do that or the resources to deal with it. And so in their wisdom, they're saying I just can't do this, and so it's not there. And so it's not a denial of I'm not willing to deal with reality, but just not being there. So it's much more complicated why those numbers are low. But I certainly agree with you. I think you just spoke to most oncologists. Most cancer patients have some degree of suffering from their diagnosis. Now, whether it classifies it quote major depressive disorder, generalized anxiety, but certainly causes some distress.
Oh, and it's such a great point about the masking of that depression or anxiety or distress, whatever you want to call that symptom, that some of it is a coping mechanism so that we can just get our shit together and go to chemo or get through the next surgery or whatever it is. Some of it too is managing other people's emotions, because when you say, hey, I'm feeling bad, then you have to manage, I have to manage my emotions, and also I have to manage someone else's emotions.
That's right.
And you just learn to kind of hold it in, and the fact that that then affects the tools that we use to diagnose the symptoms that we're feeling is just such a great point. I also want to talk about dosing. You have a study looking at two doses. I think the study is literally called two dose, if I'm not mistaken, and that's compared to other studies that's a single dose of psilocybin. Would love to hear a little bit about why you're looking at two doses, the hypotheses that you're testing in one versus two dose.
Yeah, so the two dose studies, not necessarily two doses, but two different dosages, but two treatment versus one. And so the first study, we gave psilocybin 25 milligrams, and there that we found 80% of the people had a 50% reduction in their symptoms, and 50% went into what we call remission. So the question we had was, if people got a second dose, did we increase that number of 50%? Did two doses help more than one dose? And so that's why we did that study. But the dosage question, I think, is really important. And the more I do this, the study that I would want to do at some point is looking at different dosages, because I actually think less might be more. And that people having big doses have such a big experience, and they maybe take away 15-20% of what they could out of it. Whereas a lower dose, they may be more cognizant and able to get more out of it and use that integration over a longer period of time. So I'm not convinced that more is always better, and we just have never asked that question. It's just been traditionally thought that big is better, but I just don't know anymore. I really wonder if less is more.
And this is one of the things I wanted to do in this conversation, is kind of tiptoe out to the knowledge frontier and talk about some of the areas that you're curious about. And one of them you just brought up, which is dosing. And you said less is more, less can be more. And sometimes when I think about less is more, I usually think about that in terms of side effects, right? Is if you lower the dose, you're less likely to have side effects relative to any benefit that you get. I think I hear you saying something different, which is that less might actually lead to more benefit in terms of the experience. That's kind of counterintuitive as I normally think about it. Tell us a little bit about the underlying hypothesis around why less might actually be more.
Well, I think that, yeah, so that is what I'm saying. I think less drug might be more beneficial. I don't think more drug is necessarily more harmful, but I think it could be less beneficial. Um, I think in less, people have more agency. And so there's not just this, oh, I got blasted out and then I had the experience and now I came back and I've got to make sense. And there's more connection to everyday reality, and people being able to make those connections and to gently walk into those gradations of like, this is my everyday reality and this is altered, this is more altered, and this is the places I'm going in, and I can step in and out and be able to explore those things in a more manageable way. Um, may not create the immediate effect the next day, but I think over time they may be able to integrate that more than sort of a, wow, I had this crazy experience. I saw all these things, it was really powerful in the moment, and now like bam, I'm back to the way I feel every day. And I think it may be able to be integrated more. And then I think for a lot of people, there's a lot going on. There's a lot inside, and to sort of, you know, blow it up and get it splattered and then try to put it back together. That's one way to do it. But another one way may be more gentle and sort of take things apart, deal with a bit at a time and do it over time rather than just sort of like, you know, take a big hammer to it. It's just a bit more nuanced.
Yeah. And I'm curious if you had an infinite amount of money and an infinite amount of time, what would that study design, what would that trial design look like to test that dosage hypothesis? And let's maybe focus in on psilocybin. If 25 milligrams is kind of the current benchmark, what would that design look like?
Well, I would want a lot more upfront assessments, in terms of imaging and biological data and genetic data, as well as a much deeper psychological assessment beyond the scales. So I could really help um, describe and phenotype the person, both in terms of their biology, their imaging, the blood work, but also their psyche and having more and more new understanding of it. And then I would give people different doses, like maybe 5 milligrams, 10, 15, 20, and 25, and then follow people over time and see different phenotypes and where they are, how they respond to the different medicines.
Interesting. You talked about psychological assessments beyond just the scales. What do you have in mind there?
I think the next generation of assessments will be more than somebody asking you questions and putting them down on a piece of paper. And so, some interesting work that we've done with the University of Vermont is around analyzing video of conversations. Can you train to look for certain things that may not be necessarily captured by scales like that? And so they've coded for, there's a paper that came out looking at awe. Can you sense if somebody has awe? Another one was coding connection between the therapist and the person. So I think that we'll get more measures. And with emerging AI technology, I think those assessments may be better than sort of human questionnaires. So I think that's one
Fascinating.
direction we're heading.
Yeah, that's really interesting. And that is based on body language and tone of voice, and they're drawing those
Yeah,
assessments.
the words that are
Interesting.
used, the language that's used, eye, heart rate, a lot of multitude of things. Yeah.
And that gets beyond some of the challenges that you mentioned earlier with masking self-reporting of some of those symptoms. Is right now all of those scales are self-reported, and there are all sorts of kind of implicit things that we can measure. So, okay, really interesting. I'm curious, what other areas you're curious about? What other hypotheses would you like to test, or where you mentioned earlier that you feel like you know less today than you did 5 years ago about psychedelics and cancer? Where are those big areas of question for you?
The dosing question gets at some of that, but I still think we have a lot of work to do to see who's it right for, who uh, who's it unsafe for. I think we're at the very early days of that still. We know a lot, but I think there's a lot more to learn around that. Uh, and then I think there's lots of things that we're not studying yet. Like we're studying mostly symptomology and disease categories as we're trying to get these drugs, approved and more accessible. But there's lots of interesting questions around the human mind. Is there a difference between the mind and the brain? How do you assess for that? And um, what are subjective experiences? What is happening there? I think there's a lot of epistemological questions that can be asked in these things that I think are important both for therapeutic value, but also just from the practice of medicine. So I'd love to do some studies around that.
Yeah, yeah. Okay. Well, let's go fundraise, Manish, and give you a bunch of money so that you can go out and do these
All right.
do, do these studies. Um, I'm also curious about. We've talked primarily about psychosocial symptoms, depression, and so forth. I'm curious about psychedelics for physical symptoms, pain. I saw a paper on pain in psychedelics for cancer patients recently, and I'm just curious your thoughts on that. And is there ever any future where Sunstone would look into some of those physical symptoms beyond the psychosocial symptoms?
Yeah, I mean, I think we've never done that formally. There are pain studies going on. Just anecdotally, we did see on uh, some of our participants that I remember one gentleman, in particular with prostate cancer. It's not that his pain went away, but his relationship with the pain changed. And so, pain is, again is reported, and so the pain didn't bother him as much. It wasn't that it went away, but it just wasn't affecting him. He started walking differently. So I think there's a lot of nuance there to study. And so I think some good pain studies would be very well warranted. The recent sort of reintroduction of psychedelics, was done by this palliative care in Chicago. His name is Katz, and he actually was studying LSD to study pain. And so he was given pain. He was given LSD to people in the hospital with pain that had cancer, and it was helping their pain. But what he saw was like their suffering was reduced and the psychological symptoms, and that's how that evolved. And they said, "Oh, it seems to help the psychology, and then if you provide support, it seems to help even more." And then sort of it turned fully into that. But it wasn't helping pain at all, which he did report. So I think that it's sort of going back to its history.
That's interesting. And that was 5 or 6 decades ago. In some of the early research on psychedelics was interestingly in pain. The thing that you said earlier about your patient who changed his relationship to pain, that sounds really important too, because I don't know if there's a mechanism by which psychedelics might affect physically in the body the source of pain, but the psychological relationship to pain feels potentially powerful.
Yeah, I mean, I think, and just tease about which is happening. Is it both? Is it one more than the other on which person?
Yeah, yeah. Okay. All right. Well, good. If you think out 5 years, you've been doing Sunstone for about 5 years. If you think 5 years into the future, what is your vision for what Sunstone's going to look like and how it might look different than today?
Well, I think 5 years from now, there'll be drugs that are approved for the treatment, of mental diseases, whether it's in cancer patients or not. So I think at that point, we'll be doing a lot of treatment that's standard, so instead of like just research treating people, and I think we'll be able to define much more what an individual person needs. It'll be more personalized. So if you came in, I might say this dosage with this drug for this reason, and then we should assess and then see where that is and be able to help tailor a much more personalized path. And I think we'll have much more nuanced understanding of what support is best. Um, but I hope, at that time, the vision would be that a lot more people have access to it than do currently. That would be covered by insurance, and that we're able to provide, really safe care for people that are suffering with this. And not everyone gets psychedelics, but we're able to assess who does.
And we're talking about safety and access again. I think those are two really, really, really important points. To unpack those a little bit, in terms of safely providing psychedelics for cancer patients, what would that look like if there are approvals in the future? What do some of those safety protocols look like so that patients are getting the right medicines and getting them safely?
Well, I mean, one is to really assess who it's right for. So not psychedelics are right for everyone. And so we rely on people with certain, like the history of schizophrenia, psychoses, but there's more nuanced and to really understand what's happening with the person. And I think the other around safety is the treatment center and the clinicians. And so I think a lot more training has to be done around that so that the people that are there are equipped to be able to treat and take care of the people there. Because if people have big and powerful experiences, the people in the clinic have to know how to handle that. And I don't think we're there yet.
And you also talked about access, and healthcare access writ large is a challenging topic. And when we think specifically to access to psychedelics, what are your thoughts on what that access model might look like and how we can provide as much access, safe access, to as many patients as possible?
I mean, I think primarily when people have access, at least in this country, is around insurance. And so to have insurance coverage, so finance is a big thing that sort of is a barrier to it. And some of that's going to come down to prioritizing mental health. We tend to pay for procedures and medical devices, but not necessarily for mental well-being. And so I think prioritizing that as a society and acknowledging the impact that has, and then really working with payers to be able to reimburse for that, I think is going to help access.
Payers being insurance companies that pay the
And
bills.
Medicare, and Medicare and the government and things like that.
So as you think about that future where folks have safe access to psychedelics, I'd be curious to know what is the role of patient groups like Healing Cancer Journeys in having that vision come to fruition.
Well, I think a really important thing is around education and awareness. I think that there's a lot of people that are interested in this but don't know enough and don't always have the right information. And there's a lot of hype and misinformation. So I think um, having a safe place where people can go and learn and then talk to others that have gone through the journey without even entering the medical system, I think is a really important place. And then even as they finish their journeys, coming back to have resources. Not everything has to get medicalized. And so there's a lot of sort of wraparound that has to happen around the psychedelic journey. And I think groups like yours can certainly help a lot with that, to raise awareness. There's lots of cancer patients that still don't access this that really could benefit because there's just no awareness, or even like they think this is drugs and I shouldn't do it. And so really educating the community on, could this be right for you, if you're, and not educating on psychedelics, it's almost educating on mental health and educating on how, there's nothing wrong if you're depressed. You're actually having a normal response to a hard situation, and there's things that could help you. Some of it might be therapy, some of it would be talking to a friend, but maybe it's psychedelics. And so normalizing that, and raising awareness and education is hugely needed.
Yeah, I think that's right. It starts with awareness and moves on to addressing some of the stigmas around. Just talking about cancer is hard, but also talking about mental health in cancer is even harder. And then talking about psychedelics for mental health in cancer is tremendously hard. And so addressing both the awareness challenges, the stigma challenges, I totally agree are really important. All right, Manish, two final questions for you. One, if there are two people that we want to invite onto a future Healing Cancer Journey podcast, who should we have on, and what are some of the big ideas that they might be able to contribute to the community?
There's a really, really smart psychotherapist in England, Liam Maudlin, who's one of the best that I've sort of heard talk about the psychedelic journey itself. And I think he'd be a great person to talk to in terms of what the psychedelic experience actually is like in the sessions and what are safety issues. I think he's a very bright guy that's worth thinking about. This specifically on cancer and psychedelics?
Yeah, cancer and or psychedelics. Anything kind of relevant to the cancer community to accomplish the objectives that you talked about earlier around awareness, education, reducing stigma?
I think who's another person I would recommend? Let me come back to that, because there's lots of people, but I think having, I don't know if you've had a patient on or not, but I think having a patient experience is really powerful. I think that can be someone that's gone through it, and if they've been willing to talk about it, I think is really powerful.
Totally agree, and that's another huge part of our mission is just elevating those stories, elevating those lived experiences among patients. All right, Manish, last question. If folks want to follow Sunstone Therapies, follow you, where do they find you online? Where do they find you on social media?
Our website certainly has lots of information on Sunstone, and I know I've got some social stuff that I don't even know what. I'll have to have Laura give you that information. I know there's ways to follow me, but I don't know what they are.
All right, good enough. We're not going to delve into your social media habits or expertise. So,
but their website is a good place to start.
Good. Well, we'll point folks to the website. All right. Well, Manish, before we get wrapped up, any other words of wisdom for the community before we let you go?
No, I mean, I think it's great work you're doing. I think I would just say again, if anything to leave for the community is like, the symptoms you're having are not because there's something wrong with you. There's not a problem. You're having normal symptoms for a hard situation that occurred to you. And so you shouldn't feel like something's broken because you're having these symptoms. This is a normal response to an abnormal situation. And that you should really seek help for that, and there are good places. It doesn't necessarily have to be psychedelics, but don't sort of live with those feelings without seeking help.
Manish, thank you. Thank you for the work that you've done as an oncologist, as a clinical researcher, and as a human being that's showing love to patients and people living with cancer. Thank you.
You're welcome.
All
Thanks,
right.
Dan.
Thanks. All right. I'm going to stop